I'm Jeff Hall, the Senior Editor for Diagnostic Imaging. In a recently reported survey published by the journal Academic Radiology, researchers found that out of nearly 2,000 women between the ages of 40 and 49, over 53% said they did not have a screening mammogram in the past year. According to the survey, over 38% of those who did not have a mammogram said they had no reason to get one or had never thought about it. In regard to patient education, the National Comprehensive Cancer Network recently issued updated patient-facing breast cancer screening guidelines for ductal carcinoma in situ, invasive breast cancer, and metastatic breast cancer. I recently spoke with Dr. Amy Patel about the NCCN guidelines and the potential impact they may have on patient education. Dr. Patel is the medical director of the Breast Care Center at Liberty Hospital in Kansas City, Missouri. Dr. Patel is an assistant professor of radiology at the University of Missouri, Kansas City, and president-elect of the American Association for Women in Radiology. Now let's get to the questions for Dr. Patel. Now, the National Comprehensive Cancer Network recently issued updated patient-facing breast cancer screening guidelines for ductal carcinoma in situ, invasive breast cancer, and metastatic breast cancer. From your perspective, how important are these guidelines for patients?
These recommendations are evidence-based guidelines that are formulated by experts across the country that represent over 24 cancer centers, the most prolific ones in the country. So these are very cutting-edge, evidence-based guidelines from leading experts, not just in the United States, but the world. And these guidelines are very important to educate our patients. Patients often are very, very nervous when they are in this situation of being diagnosed with a breast cancer, no matter if it's an in situ cancer, invasive cancer, if it ends up being, a metastatic malignancy. So them having this information is incredibly crucial. And, something that is digestible as well is important. Now, on the flip side, one could argue that the guidelines and the PDFs that have been put together for these patients have a lot of information, and I absolutely agree. There is a plethora of information at patients' fingertips, which could be perceived as being a bit overwhelming to the patient, saying, "I'm just not sure, how to delve through this." But there are some patients that want that more information and want the detailed information, and so having that there for patients, I think, is critical. Even more critical is that we as the providers, the radiologists, the oncologists, the surgeons, everyone a part of the multidisciplinary care team, we need to truly understand these recommendations so that we can best educate our patients. They often come to us for the information. They often listen to us for our recommendations. So we, as a cancer community, need to be knowledgeable and aware of these guidelines so that we can educate our patients effectively.
Now, all three sets of guidelines discuss standard imaging in a diagnostic workup. Is there any particular area of breast cancer imaging where you have seen maybe the most anxiety or concern from patients? And what steps do you take to alleviate those concerns and help patients feel more comfortable about the imaging being utilized?
Sure. So I think that anytime a patient comes in for a breast imaging evaluation, there is a modicum of anxiety that comes with the examination. Particularly, we see maybe heightened anxiety, particularly when we read a routine screening mammogram and we may see a finding and we call the patient back for an additional testing, otherwise known as the diagnostic mammogram, and then evaluation if the patient needs an ultrasound. Specifically in that encounter, I think patients can get nervous, but we often reassure patients that the majority of times when you're called back, it ends up being nothing, a benign finding or a negative finding, and so we try to give them that reassurance. We also see anxiety specifically when we're recommending a biopsy. So we've done the diagnostic workup, whether we called the patient back from a screening mammogram or the patient came to us with a symptom, whether it was a palpable abnormality or focal pain or some sort of symptom, and we're recommending a biopsy. That can be a very nerve-wracking time because now you've taken it to another level. So just reassuring them, with our patients, we are cognizant of the anxiety this all brings, and specifically when we make a recommendation for a biopsy, we talk the patient through the biopsy. We tell them how long it will take. We literally talk them step by step how the procedure is performed. We also send them home with a pamphlet that discusses the biopsy, because we know at the time of the interaction, we are throwing a lot of information at them. And maybe not all the information will get absorbed. Maybe all they're thinking in their head is, oh my gosh, I have cancer, I have cancer. So we want them to have that additional information that when they get home, they can process it, they can read it at their leisure, and then if they have questions at the time of the biopsy, we can answer them accordingly. Specifically, though, for the patients that end up having cancer, obviously that is very anxiety-provoking as well. When we do a biopsy and the results return, at our breast center, if it's a positive diagnosis, we do call the patient and talk to them about the results. And that in and of itself is can be very disconcerting for patients. But again, reassuring them that they are in good hands and specifically dissecting what their clinical profile is, such as if it's an early grade breast cancer and what does that mean for them, what could potentially be offered down the road, what are our next steps. We typically, our next steps is we set up our patients to see the breast surgical specialist, our breast oncology navigators do all of the arrangements. So just sort of having that next step picture that we can share with patients to say, you're not alone, we know what we're doing, these are the next steps, I do feel provides a lot of reassurance to patients.
Now, these guidelines also emphasize having a good knowledge of the family history of breast cancer. What ballpark percentage of your patients have that working knowledge of family history coming into an imaging appointment? And what kind of impact could that family history have on the imaging exam or workup?
Sure. So, I would say that we are very fortunate. We have a very aware, knowledgeable population, and I would say maybe 75 to 80% of our patients can provide a fairly thorough family history. And I was just talking about this same question with our lead geneticist just yesterday, and she agrees that it's probably somewhere around 75 to 80% of our patient population. And knowing that genetic profile, it's so important, that family history, because as you know, Jeff, this can affect many generations, especially if, let's say, a woman is a BRCA carrier. This could most certainly affect her children, her first-degree relatives. So it's very, very important. So I was really pleased to see that the NCCN came out recommending that women are risk assessed by age 25 and reevaluated every 1 to 3 years. I think it's incredibly important because we know that family history, it plays such an immense role to our overall risk. It isn't the only role that plays towards our risk, overall risk for breast cancer, but it does play quite a role to contribute to our overall percent lifetime risk.
Now, was there anything about the imaging section of these guidelines that you found particularly noteworthy or helpful in regard to patient education?
Yes, I was so pleased to see that the NCCN is recommending annual screening mammography in average risk women beginning at age 40. Because there is so much confusion around screening recommendations amongst the various groups that recommend variability in screening guidelines. And so for the NCCN to be on the same page with groups such as the American College of Radiology and the Society of Breast Imaging was very wonderful to see, because we know that starting mammographic screening at age 40 in average risk women has the best mortality reduction benefit for the patient. So we are so pleased to see that as a breast imaging community, that one. And also specifically with our above average risk patients, in addition to mammography, recommending breast MRI. We know breast MRI is our most sensitive screening tool, supplemental screening tool. And so that has been really wonderful. In keeping with our recommendations, the American College of Radiology and Society of Breast Imaging came out with recommendations in above average risk women in 2018. And so these recommendations are now all in alignment, which again mitigates confusion behind variability in imaging recommendations. They also came out recommending what we are recommending as well. If you are above average risk, starting mammograms at age 30 and breast MRIs at age 25. So again, the more we can get on the same page with screening guidelines, whether you're average risk, whether you're above average risk, I think it's better, especially when it comes to mitigating confusion amongst patients. I also particularly have to say kudos in regards to the screening guidelines for pregnant and lactating women. I think that, historically there has been misconceptions or some anxiety around imaging pregnant patients, but we know that the radiation risk to the fetus is minimal, and we can do things like shield the belly to minimize that risk even more. So, it's so important not to delay your imaging in those situations. If you're lactating, make sure you're pumping, before you have the imaging examination. But I was really, really pleased to see that as well. So again, the more that we can get in alignment across multiple organizations, the best it will be to serve our patients.